I'd like to invite Dr. Bijiraj Vathvam Veetil to shed light on the topic, decision making in OSA. I'd also like to invite Dr. Jabir bin Umar KP, consultant, ENT specialist and head and neck surgeon at Baby Memorial Hospital, Kannur, to kindly chair the session.
We're honored to welcome Dr. Bijiraj, Senior Consultant at Ascent ENT Hospital, Kozhikode. He has received advanced training in obstructive sleep apnea surgeries under Dr. Kenny Pang in Singapore and holds a fellowship in sinus and anterior skull-base surgeries from the World Skull-Base Foundation. His principal areas of clinical interest include obstructive sleep apnea, rhinology, and anterior skull-base surgery. A distinguished member of the Indian Association of Surgeons for Sleep Apnea, Dr. Bijiraj has been invited as a speaker to multiple conferences and is a faculty at the mini fellowship course conducted by the Asia Sleep Center in 2024 and is scheduled to speak at the Royal National ENT Sleep Surgery course in London in 2025. Over to you, sir.
Shall I start? Good afternoon all. So first of all, let me thank Dr. David and Sanu for giving me this opportunity. And this is the place where I belong to, Ascent ENT Hospital. Every patient with OSA who comes to our OPD is not just seeking treatment, they are seeking transformation. Transformation in their quality of life, sleep, etc. And this specialty of OSA is no longer ruled by a single department. It is managed by a group of doctors like ENT, then dental, pulmonologist, pediatrician. Everyone have their own role and they have challenges in treating the patients. And the real question is, how do we decide? That is, when to do a surgery, when to refer this patient to our colleague, or when to reassure the patient, and so on. So this is the main thing, when we compare the disease to another diseases like CSOM or otosclerosis, we have one or two standard protocols to treat that patient. But here, from the morning onwards, we are realizing that this is not a single procedure is not there to treat the patients. That is the problem in treating OSA. So this talk will be like a revision of what we have learned from morning onwards. And the decision in treating the patients are needed at almost every step of the way, and that may change in all step of evaluation and treatment. At any step, your protocol can change. There is no definite protocol for treating an OSA patient. So before making a decision, one should have answers for these questions. Is this patient is a right candidate for me? Or otherwise, is he going to eat my head for my lifelong? If it is like that, you have to be a little bit cautious. Then how much the patient is motivated? Because OSA is a disease or a problem where patient motivation is very important. He have to change his lifestyle, he have to change his diet habits, exercise habits, everything. So he should be motivated. Then the patient reality is matching with the expectations, because many of the patients will expect 100% mute sleep, but that may not be the situation always. And is he ready to accept long-term outcomes like a need of a resurgery or a CPAP in future? Are they ready? Then are they ready to accept complications like a post-op bleeding or some airway issues?
Hello, 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 hello.
I don't know. It's not me. And one more important thing is my setup and infrastructure is enough to deal with this patient. And the final, after getting all the answers for these questions, am I going to deal this patient surgically or not? So one should have answers for these questions before starting treating a patient. And we have to be careful when a patient like this come to your OPD. Like patient is happy, sleepy, but his wife is little bit very tensed because she is expecting a 100% mute sleep. She don't worry. I think she most of the cases she won't be bothered about the OSA part, apnea. So there you have to be careful. And patient can come to you in any forms, like a normal lean patient or a little bit obese or a more obese patient. So at the first sight only, when he is sitting in your OPD, you have to be like, okay, is this right patient is right for me? Like this patient actually, he came to me for surgery for OSA. Directly he told, I want to treat my OSA with surgery. But looking at him, you can know, or otherwise from the morning onwards, we are realizing that skeletal deformity, obesity, everything is like a negative predictive factor for surgery. So we have to be careful. So we have the evaluation part, we have already did. In that, I just want to share one thing, that is importance of video and audio recording, at least in the beginning of your career, whether to identify whether patient is having snoring or patient is no sound. Patient is going for apnea, we can understand from just a video recording, maybe some 2 to 3 minutes video recording. It has 83% predictive value in identify the snoring. Like a simple snoring or an OSA or some other sleep disorder. Or else if it is not available, at least get a video recording, audio recording of the same thing, which has 75% predictive value. And if you are not, at any point of your treatment, if you are not, like if you don't have a solid decision, you can ask your mentor or your seniors for the thing. So OSA should be, the treatment of OSA should be tailored and offered to everyone so that the patient will get the best decision, the treatment. And you have to recommend CPAP, or if the CPAP is not fitting, you have to go for BiPAP. And in pediatric population, we have already learned that there is a role for maxillary expansion also. So the current concept of OSA management is like patient-centered care in OSA management. That is, we have to engage the patient to decide his treatment. It's not only our decision, we also have to engage in the decision thing, and we have to promote the literacy, health literacy. So patient engagement is, we have to make sure. So after your primary evaluation, we have these findings, and according to this, in this, if there is high BMI, skeletal deformity or syndromes, we have to be careful. So after the evaluation, you have so much findings, and these are the options, primary options available for you in a single one or like combinations. So we have to decide accordingly. There is definite role for nose, but we have already learned. But when a patient, we have already learned that if there is a patient with a narrow nose and a high-arched palate, you have to be careful. And especially in kids with adenotonsillar hypertrophy and OSA, if there is severe skeletal deformity, we have to tell the parents that this kid will be having mouth breathing in future, and we have to go for a dental treatment. That also we have to make sure. There is a role for rhinoplasty, we have already discussed. Then there is a paper out in Sleep and Breathing Journal. That is according to them, they have identified the predictive factors for surgical failures in OSA. That we have to keep in mind. That is, one is incorrect patient selection and incorrect surgical planning. Then inadequate post-operative care, severity of the disease, higher the BMI, advanced age. That is very important. When a 65 to 70-year-old patient comes to you with snoring and apnea, better not to go for any surgical procedures. Then involvement of multiple airway sites, and always the skill and experience of the surgeon. And before starting a treatment like a surgery, or if you are planning any upper airway surgery, we have to make sure that the mouth opening of the patient is adequate. That is very important, because the intubation, surgery, even if you do the intubation or surgery, if some post-operative complications happen, you will be in trouble. So always check for mouth opening. Then we have the DISE, a detailed session is coming. For me, DISE is the only procedure which can offer a 3D direct visualization of airway during sleep, and with DISE or with the findings of DISE, I can discuss the findings with the patient or the attenders, and so that they will be more confident. That is what I felt. So DISE definitely have a role. So after your DISE, now we are into the surgery. What to do first? Like we have a nasal problem, then we have a palatal problem, we have a tongue base. So what to do first? So if you have a nasal pathology along with a palatal pathology, always better to go for palate first, because at least in the beginning of your career, I think the suturing methods, everything will be little bit difficult in palate. So finish off that first and then go for the easy part, that is a nose, first thing. Second thing, once you do the palate, once you do the nose, definitely there will be trickling of the blood into the palate or the oropharynx, and that can cause interference in your surgical field. So always better to do palate first. But it is an epiglottis along with a palate, I think better to go for a epiglottis first, because dealing with your retractors, everything will be difficult once you do the palate. And for extubation, usually the anesthetist people they'll be sucking the throat and all. So that better you do from your side and don't allow them, because they won't be knowing what all things you did. So better that part of, not the extubation part. Before the extubation, the suctioning of the airway and all is better to do by ourselves. Then whether to use an absorbable or non-absorbable sutures. That is also a paper is out there now. I think seniors are more experienced with that, and I am familiar with only the absorbable one. Then when you do more and more cases, there will be more failures. So when you have failures, always do a type 1 or type 2 sleep study, because to rule out other sleep disorders also. Then whether to go for a tonsillectomy or tonsillotomy, Dr. Sanu has already described. In a chronic tonsillitis patient, a little bit old kid, better to go for tonsillectomy, and if it is a younger kid with obstructive symptoms, go for tonsillotomy. Then the role of nose, when there is a severely deviated septum, it's better to correct it. Yeah, even in the young age, like 6 or 7 years, we used to correct the septum, and the results are good. And obviously the turbinate also. There are turbinate vans now available, which will shrink the turbinates. Then in persistent pediatric sleep disorder breathing, always a flexible endoscopy is recommended to rule out the residual adenoid and also the lingual tonsil. And DISE is done in pediatric population, especially to rule out the tongue base issues. So let us discuss some cases. And this was a patient who, one of my colleagues did the case. It was a patient with a moderate sleep apnea, a normal BMI, and they did a DISE. So there was a circumferential collapse at the velum, and also he told there is a epiglottic collapse also. So that is collapse at both palate and the epiglottic region. So he was asking me what to do first. So the main issue was that was not in the palate or this one, tongue base, that was in the skeletal problem. There was a retrognathia. So in this kind of cases, when you get a normal, like not obese patient with a multiple airway collapse, you have to evaluate the container box. That is, just look at the patient and see whether his skeletal system is okay. Especially when the patient who comes with beard and all, you won't be knowing how much retrognathia he will be having. So that you have to rule out. There's a second case. I think sound is not there. He was a 22-year-old male patient. Video is not working. With his BMI was 45, and He had snoring, all the features of a severe sleep apnea. So, this was he. You can see. So first of all, we gave a CPAP. He was not ready for it. He was not like comfortable with the sleep app. He was not ready to lose the weight also. He had a grade 4 tonsils and adenoid hypertrophy of like completely blocking the nasopharynx. So, he had a 74 AHI. So this was his DISE finding. You can see the airway is completely obstructed by the tonsils. Sound illale. So with this was his airway. So with guarded prognosis, I did the adenotonsillectomy, just adenotonsillectomy and a uvuloplasty, nothing else. And patient improved. This was his pre-op and post-op airway. The sound is not there. So even if in obese patients there is definitely a role for surgery, because as sir told, like if there is a static obstruction, if there is a structural obstruction other than collapse, there is a role for surgery. That you have to keep in mind. This was the case of an 18-year-old male patient with nasal block and snoring. His BMI was almost normal. He had an adenotonsillectomy and a septal surgery previously with a high-arched palate. This was the situation we were talking from the morning onwards. You can see there was complete synecdoche between the nose and the turbinate. So this is the issue, this is one more the issue what we will face in future, like if you do a septal correction or turbinate in case of narrow nasal cavity with high arched palate. So this kind of patients will get more, there will be symptoms wise, there will be more problematic after the surgery. Because the nasal cavity itself is narrow. So what I did was like, I removed the synecdoche, I excised the synecdoche and did a turbinoplasty, and later I sent him for a dental orthodontic treatment. So we have to be careful with high arched palate and narrow nasal cavity. This advice is actually for the ENT surgeons. And this is a case, a non-Hodgkin's lymphoma patient with severe hypertrophy of the lymphoid tissue over the tongue, that is lingual tonsils and the tonsils. It was completely hypertrophied and it was like blocking the airway completely. So whenever you are planning a surgery in this case, one thing you should be careful, that is the securing of the airway. So airway should be secured in all cases of OSA, and that is a key point in OSA surgeries. So we have to be careful. So in this case of in this kind of cases, you have to be make sure that at least you do a tracheostomy before surgery than putting him in on intubation. This is another kit. She was a Down syndrome kid, 10-year-old kid, and she was on CPAP for 2 years. Sound no sound. So, and this was her, she was using CPAP for last 2 years, and she is comfortable with the CPAP, but parents somehow want to take it out. So when I did this one flexible scopy, you can see the adenoid was almost completely blocking, and there was grade 4 tonsils and also some lingual tonsillar hypertrophy. So I did a tonsillectomy, just simple adenotonsillectomy for her, and later you can see the airway space is improved, but there is some lingual tissue remaining. I didn't touch that, and her symptoms are also improved. And this is how she sleeps now. She is not using CPAP also. So flexible endoscopic examination is recommended before starting CPAP, even in syndromic patients. We have to see the airway, what is happening, instead of just giving a CPAP. Because whenever a syndromic patient all comes, we will think, okay, this is not for me, you have to go for CPAP. No, it's not like that. And if you are planning a surgery for this kind of kids, like Down syndrome, or there is a chance for atlantoaxial subluxation when you are extending the neck. So always get an X-ray and an orthopedic fitness. So OSA is a multifactorial disease, and there is no single solution fits for all the patients, and the decision may change at any step of your management, and patient needs individualized treatment based on anatomy, BMI and motivation. You have to set the realistic goals and not perfection. And you have to combine major and minor procedures wisely. Thank you. I was a little bit fast because already it is running late, I think.
Thank you, sir. I'd like to request Dr. Reshmi Nair, Consultant Laryngologist, Madhavam Laryngology Clinic and Renai Medicity, Kochi, to kindly felicitate the chairperson.
That's all right.
Thank you, ma'am.